Welcome back to the deep dive. Today, we're plunging into a challenge that, well, it frequently confronts us in sports medicine. Posterior shoulder pain in overhead athletes. It's a condition we've come to know as internal impingement.
Mhm.
And for mid to senior medical professionals like yourselves, truly mastering this area, it isn't just vital for your practice. It's really about giving our athletic patients their careers back.
Indeed. And in this deep dive, we'll aim to unpick the intricate pathology of internal impingement, trace its historical evolution a bit, and delve quite profoundly into its unique biomechanics.
Okay.
We'll then pinpoint the key diagnostic methods you need to employ and explore the often nuanced treatment strategies, both non-operative and operative.
It was a whole spectrum.
The whole spectrum.
Yeah.
Our mission today really is to equip you with the essential understanding to approach this condition with confidence and precision. That ensures the best possible outcomes for your patients.
And as we navigate this, we're going to uncover some truly fascinating paradoxes. We're talking about things like the thrower's paradox, that delicate tightrope walk between extreme mobility and crucial stability. It allows for peak performance, yet paradoxically predisposes athletes to injury. Understanding the why behind this prevalent issue, how their very adaptations can become their undoing. That's where this deep dive truly gets interesting, I think.
Absolutely. It's a fascinating area.
So let's get started and unravel this enigma. By defining the enigma, what is internal impingement? Right. When we hear shoulder impingement, many of us, perhaps reflexively, picture that common pain beneath the acromion, don't we?
Yes, the classic subacromial type.
Exactly.
Yeah.
But internal impingement, despite sharing a name, it's a profoundly different beast. It's not just a general rubbing or catching. What precisely differentiates it anatomically and pathologically?
That's a really critical distinction to make right at the start. Internal impingement describes a very specific constellation of symptoms. It results from the forceful, repetitive contact abutment, really between the greater tuberosity of the humerus
Okay.
and the articular surface of the rotator cuff, specifically the undersurface of the supraspinatus and infraspinatus tendons as they're pressed against the posterior superior glenoid.
So the upper back edge of the socket.
Precisely. It's an intra-articular phenomenon.
Mm.
It happens within the glenohumeral joint itself.
So a very precise interaction happening deep inside the joint. And it doesn't just happen at any point in the arc of motion, does it? There's a specific moment of truth where this occurs.
Spot on. This critical contact occurs when the shoulder is in a very particular and frankly quite demanding position. Maximal abduction, usually around 90 to 100 degrees,
Right.
combined with maximal external rotation. And that often reaches an astonishing 170 to 180 degrees.
Wow.
This is the precise position the shoulder assumes during the late cocking phase of throwing.
Okay. So picture a pitcher.
Exactly. Imagine a baseball pitcher at the apex of their windup, arm fully abducted, rotated right back just before they drive forward to unleash the ball. That's the moment. That's the position of impingement.
And that's the fundamental differentiator from what many might think of as classic impingement. Why is grasping this distinction so crucial beyond just, academic understanding? What are the implications for our clinical approach?
Oh, it's absolutely vital to clearly distinguish internal from external or subacromial impingement. In external impingement, the rotator cuff gets impinged on its bursal side, the outer surface within the subacromial space.
Right, involving the acromion or the bursa.
Exactly, often involving structures like the acromion or an inflamed bursa.
Right.
Internal impingement, however, occurs on the articular side, the undersurface of the cuff, within the glenohumeral joint itself.
Inside the joint.
Inside the joint. This is a profound distinction because, well, it changes everything about our diagnostic pathway and, critically, our treatment strategies. Well, we're looking at intra-articular pathology. We're often dealing with tears to the undersurface of the cuff and the labrum, rather than just bursal inflammation or compression from outside. The repetitive microtrauma from this constant internal rubbing can, over time, lead to significant damage to both structures.
So ignoring that difference could lead us down the wrong path entirely.
Absolutely. It can lead to misdiagnosis and consequently ineffective or even potentially harmful treatment, like an unnecessary subacromial decompression, for example.
Okay, that's clear. So who are we typically seeing present with this specific pattern of pain and dysfunction? And why is it so important for us as clinicians to really get a handle on this condition now?
Well, internal impingement is a major cause of shoulder pain, and its epidemiology is quite specific. It's predominantly seen in a younger, highly athletic population,
Right.
particularly those engaged in repetitive overhead activities. Think of sports where the arm goes through that extreme abduction and external rotation consistently, often at high velocity, often with tremendous force.
Like baseball pitchers, obviously. We often hear it called the thrower's shoulder.
Exactly. Baseball pitchers are perhaps the most iconic example, yes.
Yeah.
But it's also highly prevalent in tennis players, volleyball players, swimmers, even gymnasts.
So quite a range of overhead athletes.
Any athlete performing those rapid, forceful overhead movements repeatedly, where the shoulder is pushed right to its biomechanical limits, and the clinical significance, well, it really can't be overstated.
Why is that?
If internal impingement is left untreated or inadequately treated, it can lead to chronic pain, significant functional limitations that can completely sideline an athlete.
Career ending, potentially.
Potentially, yes. And over time, it can lead to long-term degenerative changes within the shoulder joint itself. This can profoundly impact an athlete's career, certainly their ability to continue their sport, and ultimately their overall quality of life.
So early, accurate diagnosis and tailored intervention are absolutely paramount.
Absolutely. To preserve function and prevent that irreversible damage.
Given its prevalence and impact, how did our understanding of this condition actually evolve? It feels like quite a modern concept in its precise definition, but I imagine the observation of posterior shoulder pain goes back further.
That's right. The historical perspective is quite illuminating, actually. It shows a gradual refinement of our understanding over decades. The idea of posterior shoulder pain in overhead athletes has been debated since the 1950s.
Really? That far back?
Yes. It began with Bennett, who in the 1950s described posterior shoulder pain related to inflammation of the posterior capsule and the inferior glenohumeral ligament, the IGHL.
Okay.
He identified a bony growth, an exostosis, on the posterior-inferior glenoid rim, which became known as the Bennett lesion. He also noted articular-sided posterior-superior rotator cuff tears in these athletes.
So an early link between a specific lesion and this type of pain.
Yes, an early recognition of some key anatomical findings linking a specific lesion to this type of pain, although not fully understanding the mechanism yet.
So an initial focus on the posterior capsule and that Bennett lesion. What came next in sort of painting a clearer picture?
Well, the field progressed significantly with the contributions of Andrews and colleagues in 1985. They described a series of overhead athletes presenting with posterior shoulder pain, but crucially, alongside articular-sided posterior-superior cuff tears and concomitant SLAP lesions.
Bringing the labrum into it more clearly.
Exactly. Linking the rotator cuff and labrum more directly as potential co-conspirators in the pain mechanism. Then Job and colleagues in 1989 reported on overhead athletes with posterior-superior impingement that they associated with anterior instability.
Okay.
And critically, they observed that these patients did not respond well to standard subacromial decompression procedures, which was the common surgical approach for external impingement at the time.
That must have been a key observation.
It really highlighted that something intrinsically different was happening within the joint, something beyond just subacromial issues. They found these patients often had a cluster of associated injuries, labral tears, cuff tears, ligament injuries, suggesting a more complex intra-articular problem.
So the puzzle pieces were slowly coming together, pointing towards a distinct internal mechanism, not just subacromial. Sounds like an exciting period of discovery.
It was, and the definitive description, the one that truly solidified our modern understanding, arrived with Walsh and colleagues in 1992.
Watch. Right.
They reported on a series of patients where arthroscopy revealed clear impingement between the articular side of the supraspinatus tendon and the posterior-superior edge of the glenoid cavity, specifically during that maximal abduction and external rotation position.
They saw it happening dynamically.
Yes, dynamically. And they consistently found partial articular-sided rotator cuff tears in these cases. This led them to definitively describe the internal impingement mechanism, detailing exactly how the undersurface of the posterior rotator cuff becomes entrapped between the labrum and the greater tuberosity in that key position.
Yeah.
It validated the dynamic interaction.
And this precise mechanism led to that rather vivid term, kissing lesions, didn't it?
Yes, a very apt and accurate term they introduced. The direct impingement mechanism, where the cuff is literally pinched against the labrum and glenoid, it leads to simultaneous damage on both surfaces, the undersurface of the rotator cuff and the posterior superior labrum, hence kissing lesions.
Right.
So this historical progression really shows how our understanding moved from just observing isolated symptoms and lesions to truly grasping the dynamic intra-articular mechanism at play in these overhead athletes. And that, of course, set the stage for more targeted diagnostic and treatment strategies. 2. The intricate dance, pathophysiology and biomechanics. Now that we've defined it and traced its history, let's peel back another layer. Why does it actually happen? Symptomatic internal impingement. It's now understood not as a singular issue, but as a multifactorial condition.
Okay, so it's rarely just one thing going wrong. It's more like a cascade.
Exactly. It's a complex interplay of various factors that collectively contribute to its development in symptomatic individuals.
What are the key interacting elements that we as clinicians really need to have on our radar when evaluating these athletes?
The primary interacting elements are generally considered to be
Mhm.
physiologic, shoulder remodeling, the changes that happen over time,
Okay.
posterior capsular contracture, a tightening at the back,
Right.
and scapular dyskinesis, abnormal movement or positioning of the shoulder blade.
Got it.
In the past, there was quite a bit of debate. Some believed anterior instability was the sole driver, while others argued against that correlation. But the current view really integrates these complex factors. It recognizes they all likely play a role in creating the environment for internal impingement to become symptomatic.
So it's a systemic problem within the throwing shoulder complex, where several subtle alterations combine.
Precisely.
This is where we really need to zoom out and see the whole picture, isn't it? The shoulder doesn't function in isolation. It's part of this incredible kinetic chain. And if any link in that chain is weak or dysfunctional, the shoulder often ends up paying the price.
Absolutely. The kinetic chain concept is utterly fundamental to understanding overhead athletic movements, especially throwing. It describes that coordinated sequence of motion that transmits energy in a synchronized way all the way from the lower extremity.
Starting from the ground up.
Starting from the ground up, through the trunk, to the shoulder, and finally culminating in the release of the ball or the racket swing or whatever the overhead action is. It's a symphony of sequential body movements.
A symphony, I like that. And what are the essential elements of that symphony?
Well, you need powerful leg drive, efficient body rotation, robust core strength, precise scapular position and motion, all culminating in that dynamic shoulder rotation. These are the essential elements working together.
So the critical insight here is, if that symphony is out of tune, even subtly, maybe the core isn't firing properly or the hip mobility is restricted, the shoulder ends up absorbing tremendous strain rather than just transmitting the energy efficiently.
You've hit the nail on the head. Inflexibility, weakness, or any imbalance at any point in this chain can cause the arm to lag behind the legs and trunk. This places the throwing shoulder in a vulnerable position. And this significantly increases the stresses across the shoulder joint itself, particularly during those high-demand phases, ultimately leading to injury. If the core isn't strong enough, for instance, the arm has to work much harder to generate velocity, putting far more strain on the glenohumeral joint during that critical late cocking phase.
It makes perfect sense when you think about it like that. And the throwing cycle itself is broken down into distinct phases, isn't it? Each with its own biomechanical demands. For those of us who maybe don't analyze throwing motions every day, could you walk us through those phases, highlighting the ones most relevant to internal impingement?
Certainly. The throwing cycle is typically divided into 6 distinct phases. The first 3 are the wind-up, early cocking, and late cocking phases.
Okay.
These initial phases collectively account for the bulk of the total throwing motion time, roughly 1.5 seconds, believe it or not. Their main purpose is to allow for proper positioning of the lower extremities, the core, and the arms, essentially setting the athlete up for the powerful release. This is where energy is generated and stored elastically.
So a relatively long, deliberate buildup. But then there's that moment of truth you mentioned earlier, the late cocking phase, which sounds pivotal for impingement.
That's right. The late cocking phase is this specific point where the shoulder is placed in that position of maximal abduction, 90 to 100 degrees, and maximal external rotation reaching that incredible 170 to 180 degrees.
The extreme position.
The extreme position.
Yeah.
And it's this extreme abducted and externally rotated position that makes it the common vulnerable position for internal impingement to occur as the rotator cuff tendons get pinched against the posterior superior glenoid rim and labrum. This is where the potential for injury is really highest.
Got it. And after that peak stretch comes the sheer explosiveness of the throw itself.
Yes, the acceleration phase. Now, this is the shortest, but arguably the most impactful phase. It lasts only about 0.05 seconds, incredibly quick.
Tiny fraction of a second.
Tiny. But it's where the greatest angular velocity change occurs across the shoulder joint. It reaches over 7,250 degrees per second.
Wow, that's astonishing speed.
It's actually been described as the fastest recorded human motion. So, given that extreme velocity and the immense forces involved, it's not surprising that this phase accounts for many injuries in overhead athletes, even though the impingement itself often occurs in the preceding late cocking phase.
Okay.
And finally, we have the deceleration and follow-through phases. These are crucial for managing the powerful distraction forces generated as the arm is rapidly slowed down after ball release. This process takes about 0.35 seconds. An inefficient deceleration phase can also lead to further injury, as muscles work eccentrically against these huge forces.
Right, controlling that massive energy release. This brings us nicely to where it gets really interesting what we've termed the thrower's paradox. It seems almost counterintuitive. The very adaptations that allow an athlete to excel, to throw harder or faster, can also predispose them to this type of injury. How does this paradox actually play out in the shoulder's anatomy and mechanics?
The thrower's paradox really does highlight the delicate, almost precarious balance between mobility and stability required for high-level function in these athletes. Pitchers, for example, need an expanded arc of motion, particularly maximal external rotation, to generate those incredible velocities upwards of 7,000 degrees per second.
They need that range.
They need that range. Yet this extreme mobility must be balanced with adequate stability to keep the humeral head centered within the glenoid fossa, preventing it from migrating superiorly or posteriorly and causing that internal impingement.
So they gain this huge range of motion, but potentially at a cost. What are the specific adaptive changes we actually observe in these shoulders over time?
Well, over time, the repetitive high stresses of throwing lead to specific adaptive changes in the throwing shoulder structure. These typically include an increased retroversion of the humeral head and sometimes the glenoid itself.
A subtle twisting of the bone.
Essentially, yes. A subtle bony twist that allows for more external rotation. Crucially, they also often develop increased anterior capsular laxity. This is a condition Job originally described as subtle instability or microinstability. It refers to a very slight, often asymptomatic increase in the looseness of the anterior capsule, the ligaments at the front of the shoulder.
And this laxity, this looseness at the front, seems to be a point of some debate in the literature, doesn't it? Is it actually a protective mechanism, allowing more give, or is it pathology in the making? How do you, in your clinical practice, definitively differentiate between a beneficial adaptation and a subtle pathological instability that's setting the stage for a deeper injury? Are there nuances we might miss?
That's a key and very subtle clinical question. And yes, there is debate. We know from cadaveric studies, MRI studies, and even arthroscopic findings that some degree of contact between the rotator cuff and the posterior superior labrum is actually a normal, physiologic occurrence in asymptomatic shoulders, especially in throwers.
It happens even without pain.
Exactly. Some authors even suggest that this adaptive anterior laxity might protect against impingement by allowing more movement, more play, and preventing that direct pinch. So a certain degree of laxity is normal and potentially beneficial for a thrower. But this isn't the full picture. While these adaptations allow for increased external rotation, they can paradoxically lead to remodeling of the posterior soft tissues. This often results in contracture or tightening of the posterior capsule and the posterior band of the inferior glenohumeral ligament.
So the front gets looser, but the back tightens up?
Precisely. And this posterior tightening, despite maintaining a degree of overall stability, ultimately contributes to internal impingement because it alters the precise way the humeral head translates or moves within the glenoid during the throwing motion, particularly in that late cocking phase. It tends to shift the contact point posterior-superiorly.
So even as the front becomes lax and mobile, that posterior tightness fundamentally alters the joint's intricate mechanics.
Exactly. This altered biomechanics, often combined with that subtle anterior instability, creates increased torsional and shear stress upon the biceps anchor at the top of the labrum and also on the undersurface of the rotator cuff itself.
And these are the forces that lead to damage.
It's these altered forces and mechanics that can lead to that cascade of specific injuries we see. Rotator cuff tears, usually partial, articular-sided, labral tears, often as LAP lesions, capsular injuries, chondral injuries to the cartilage, and even biceps tendon pathology. It's a testament to the shoulder's incredible design, but also its vulnerability under these extreme, repetitive stresses.
And we even have strong evidence for this mechanism from laboratory work, don't we? Thinking about the posterior capsule's role.
Yes, the work by Grossman and colleagues using their cadaver model was quite striking in demonstrating this. They showed how simulating a posterior capsular contraction directly leads to GRD, glenohumeral internal rotation deficit, and causes a posterior superior translation or shift of the humeral head during the simulated late cocking phase.
Right.
And this abnormal translation they found ultimately resulted in SLAP injuries, specifically through that peel-back mechanism where the biceps anchor is literally peeled away from the superior glenoid due to the altered forces.
Wow. That really underscores how complex the shoulder's biomechanics are and how these adaptations, initially helpful perhaps, can become maladaptive and pathological over time.
Absolutely. It's a very fine line.
That brings us directly to GIRD, which is such a key clinical finding we often see or should be looking for with internal impingement. Can you elaborate on what GRD actually is and what its presence truly signifies for us as clinicians? Is it just tightness?
Right. GRD. Glenohumeral internal rotation deficit. It's defined simply as a loss of internal rotation in the throwing shoulder when you compare it to the non-dominant arm.
Okay.
This loss is almost always coupled with an excessive increase in external rotation in that dominant throwing arm, often maintaining the overall total arc of motion, which can be misleading if you only check total range.
Ah, so the total range might look normal.
Exactly. You have to measure internal and external rotation specifically. Clinically, we commonly observe a loss of 15 degrees or more of internal rotation in the throwing shoulder, and the evidence suggests the potential for injury significantly increases once this threshold is reached.
Yeah.
While some degree of GRD might just be a normal adaptation in a thrower, an excessive deficit becomes problematic. It signifies a pathological shift, usually due to that posterior capsular tightness we just discussed.
So the practical insight for clinicians isn't just to measure GRD, but to understand its profound implications. A deficit over, say, 15 degrees isn't just a bit tight. It's potentially a direct pathway to SLAP lesions and increased stress on the entire kinetic chain. How direct is that correlation?
It seems quite direct. Burkhart and colleagues, for instance, found that shoulders with an internal rotation deficit greater than 25 degrees are at a significantly increased risk for developing SLAP lesions.
25 degrees, okay.
Yes. And this is thought to be due to that increased posterior-superior peel back on the labrum, the mechanism we discussed earlier, where the biceps anchor is subjected to excessive torsional forces because the humeral head can't rotate internally enough, so it shifts posteriorly and superiorly, putting tension on the biceps anchor.
Right.
Furthermore, work by Dines and colleagues highlighted its interconnectedness within the kinetic chain. They showed that throwers who had ulnar collateral ligament insufficiency at the elbow, needing Tommy John surgery, for instance, also demonstrated a significant amount of GIRD in their shoulder.
Ah, linking elbow problems to shoulder tightness.
Precisely. It indicates that problems at one part of the kinetic chain can manifest as deficits or contribute to pathology elsewhere. It truly is a whole-body system.
Thinking about that kinetic chain again, the scapula, the shoulder blade, is such a fundamental link. It's the foundation upon which the shoulder operates. What happens when it's not performing optimally? A condition we refer to as scapular dyskinesis.
Yes, scapular dyskinesis. As defined by Kibler and others, it's essentially an alteration in the normal resting position, or, more importantly, the dynamic motion of the scapula during arm movement.
Okay.
And it's a critical issue because the scapula plays a truly crucial role in overhead function. It's vital for effectively transmitting energy from the trunk to the pitching arm, acting as a stable base.
Right.
And it's equally important for dynamically stabilizing the glenohumeral joint throughout the throwing motion. When the scapula is dysfunctional, when it doesn't move correctly or sit correctly, the entire pitching mechanics become inefficient. This inevitably leads to compensatory movements and significantly increased stress on the glenohumeral joint itself.
Pitching velocity can suffer too, I imagine.
Absolutely. Pitching velocity often drops, and other muscles, particularly the rotator cuff, are forced to overcompensate, creating a vicious cycle of overuse and potential injury.
So it's not just a passive platform, it's actively involved in every movement, a dynamic anchor for the arm.
Precisely. The scapula exhibits quite intricate multiplanar motion. It rotates internally and externally, it rotates upward and downward, it tilts anteriorly and posteriorly, all happening simultaneously.
Wow.
This complex motion is dynamically controlled by force couples generated by the periscapular muscles. Think of the trapezius, serratus anterior, latissimus dorsi, the rhomboids. These muscle couples actually activate before the rotator cuff fires, ensuring that the rotator cuff contracts against a stable, correctly positioned scapular base.
So if that base is unstable or moving incorrectly.
If that stable base is compromised, the entire system starts to break down, and the glenohumeral joint is left vulnerable bearing stresses it wasn't designed to handle in isolation.
And what's the specific pathological mechanism here? How does scapular dyskinesis directly contribute to internal impingement?
Well, scapular dyskinesis often results from inflexibility or imbalances in those parascapular muscles. This can be due to fatigue, very common in athletes, or direct trauma, or even subtle nerve injuries affecting muscle function.
Yeah.
This often leads to a trend toward the scapula, sitting in excessive internal rotation and protraction around the rib cage. It might look like the shoulder blade is winging or sitting too far forward.
Right, I've seen that.
The consequence is profound. If the scapula cannot effectively stabilize the shoulder during the throwing motion, the rotator cuff is forced to overcompensate, trying to stabilize the glenohumeral joint directly.
Working overtime.
Working overtime, exactly. This transmits excessive loads to the superior glenoid, where the labrum and biceps attach, and also to the articular surface of the rotator cuff tendons themselves. This can directly lead to injury, including internal impingement and associated labral pathology. It's a foundational instability that directly impacts the glenohumeral joint, often going unnoticed by the athlete until significant symptoms emerge.
And the significance of scapular dyskinesis in internal impingement is quite stark, isn't it? It's not just a minor contributing factor. It seems to be almost universally present in symptomatic cases.
It is. Scapular dyskinesis is now thought to be an independent factor in the development of symptomatic internal impingement. In fact, some studies have reported it in up to 100% of patients presenting with the condition.
100%. That's incredible.
It underscores its almost ubiquitous presence in symptomatic overhead athletes. Therefore, addressing scapular dyskinesis is absolutely non-negotiable in any effective treatment plan, whether conservative or postoperative. Failure to correct it will likely lead to persistent or recurrent symptoms, no matter what else you do surgically inside the joint. It's truly a linchpin in the overall pathology.
Absolutely crucial then. 3, cracking the code. Diagnosis of internal impingement. Okay, we've really dug into the complex mechanics and pathophysiology of internal impingement. Now, how do we put all this together clinically? A detailed history is always the starting point, the first crucial step in diagnosis. What are patients typically telling us when they present with internal impingement, and what specific questions should we be asking to tease this out?
A thorough history is indeed paramount. It really serves as our initial roadmap. Patients with internal impingement often complain of several key issues, though they might not use these exact terms. They might describe, for example, shoulder stiffness, or maybe needing a much longer warm-up than usual before they can perform their sport effectively.
Feeling tight or restricted?
Exactly. A noticeable decline in performance is a very common complaint, too. This could be loss of control for a pitcher, or maybe decreases in pitch velocity, or a tennis player losing power on their serve.
Subtle changes at first, perhaps?
Often very subtle at first, yes. The pain itself is typically described as a deep, poorly localized posterior shoulder pain or ache. It's often hard for them to pinpoint exactly where it hurts.
Vague and deep.
Vague and deep, exactly. And it's especially prominent during that late cocking phase of throwing that extreme position we discussed. Sometimes the pain can radiate slightly to the lateral arm over the deltoid muscle, which can sometimes confuse the picture.
Okay. And the onset? Is it usually sudden?
No, crucially, the onset is often insidious. It tends to develop gradually over time without a specific acute mechanism of injury that the patient can point to. They might just say, you know, it just started aching more and more over the last few months, or my arm feels dead after throwing.
That insidious onset must make it challenging for athletes to pinpoint when the problem truly began, potentially leading to delayed presentation.
It does. They often try to play through it for a while.
And Job even classified the presentation into stages, didn't he? Which can be helpful in guiding our initial assessment and management.
He did, yes. And it's a useful clinical framework for staging the severity. Job's clinical classification of internal impingement breaks it down into 3 stages. Stage I is the early stage. This is characterized primarily by that shoulder stiffness and difficulty warming up, but notably no pain with daily activities. The athlete just feels off during their sport.
Stage I, stiffness warm-up issues.
Stage 2 is the intermediate stage. This is marked by pain, localized to the posterior shoulder, specifically during the late cocking phase of throwing. But still, typically no pain with routine daily activities. The functional impact during sport becomes clearer here.
Stage 2, pain and late cocking.
And stage 3 is the advanced stage. This presents with similar symptoms to stage 2, but the pain is now recurrent and, importantly, refractory. That means it hasn't responded to an adequate period of rest and targeted rehabilitation. This signifies a more entrenched condition, where the underlying pathology is likely more significant and less likely to resolve with simple rest.
Stage 3, refractory pain. Got it. So once we've heard their story, that compelling history, what are we specifically looking for when we actually get our hands on the patient in the physical exam? What are the telltale signs that might scream internal impingement to an experienced eye?
Right, the physical examination is where we try to bring the suspected biomechanics to life, often confirming our suspicions from the history. The classic presentation we'll often find includes tenderness when you palpate the posterior glenohumeral joint line,
Okay.
increased external rotation range of motion compared to the other side,
The adaptive change.
the adaptive change, yes, and, paradoxically, decreased internal rotation, the GRRD, in the affected shoulder. But a truly thorough physical exam needs to cover several components systematically to build a comprehensive picture and rule out other things.
Let's start with just looking. Visual inspection, often overlooked but potentially revealing.
Absolutely. First, visual inspection. We're looking carefully for any muscular atrophy, particularly in the infraspinatus fossa or deltoid of the dominant extremity, which could indicate disuse or even neurological compromise in rare cases. We also meticulously assess scapular positioning at rest, looking for any asymmetry, signs of dyskinesis, or even frank winging.
What might that look like?
Well, it might manifest as a prominent inferior medial border of the scapula, or perhaps the entire throwing shoulder appears to sag inferiorly compared to the non-throwing shoulder, sometimes due to those adaptive laxity changes we discussed. Next, palpation is key.
Where are we feeling?
We palpate systematically. Tenderness can often be elicited along the posterior joint line, confirming the likely site of impingement. But we also check the coracoid process anteriorly. The anterior joint line, the greater tuberosity, the long head of the biceps tendon groove, the AT joint, and the deltoid insertion, as these can point to potential concomitant pathology that might be contributing.
Okay, thorough palpation. And then the critical assessment of range of motion. This is where we quantify that GRRD, isn't it?
Absolutely. Range of motion or ROM assessment is crucial. We must measure rotational glenohumeral motion passively at both 0 degrees and critically at 90 degrees of abduction, isolating glenohumeral motion from scapulothoracic motion. As we've said, internal impingement typically leads to posterior shoulder tightness in the throwing shoulder and a clear loss of internal rotation at 90 degrees abduction. That 10-degree loss compared to the non-dominant shoulder is very common, and over 15 degrees is generally considered clinically significant GRRD. We also evaluate forward elevation and horizontal adduction, cross-body stretch, to assess posterior capsule tightness further.
And strength testing.
For strength examination, we focus on the rotator cuff, paying special attention to external rotation strength, often tested isometrically. The infraspinatus is the most common tendon involved in the undersurface fraying or tears seen in internal impingement, so weakness here can be significant. We also test supraspinatus strength, perhaps using the Whipple test or empty can test, though their specificity for partial tears is debated.
Okay, and what about the specific provocative tests that try to reproduce the impingement itself, helping us distinguish it from other shoulder pathologies like instability?
Yes, the special provocative tests are vital, as they aim to dynamically reproduce the impingement mechanism or the patient's specific pain. First, there's the relocation test, often attributed to Job.
How's that done?
This is performed with the patient supine, the shoulder in 90 degrees of abduction and maximal external rotation, basically, the leg cocking position. When a posteriorly directed force is applied to the humeral head, it often provokes the patient's familiar posterior pain or impingement symptoms.
Okay.
Crucially, when an anteriorly directed force is then applied to the humeral head, it often relieves the pain. This is the opposite of what you'd find in traditional anterior shoulder instability, where an anterior force would provoke apprehension or pain. A positive relocation test strongly suggests that a kissing lesion, the cuff impinging on the labrum, is being effectively decompressed by the anterior force.
That's a neat diagnostic trick. And the other key test?
The second key one is the posterior impingement sign described by Meister. This involves placing the shoulder actively or passively into 90 to 110 degrees of abduction, slight extension so the arm is slightly behind the body, and maximum external rotation.
Really cranking it back.
Really trying to mimic that impingement position. The provocation of deep posterior pain, replicating their throwing pain, indicates a positive test. This has been shown to be highly correlated with undersurface tearing of the rotator cuff and the posterior labrum.
So it's about reproducing the pain specifically in that position and then seeing if altering the humeral head's position, as in the relocation test, alleviates it. Now, given the thrower's paradox and adaptive laxity, how do you differentiate between that often physiological laxity in throwers and a truly pathological subtle instability during your exam? This feels like a key clinical dilemma.
It is a subtle but critical challenge. And honestly, it's often where clinicians can struggle. Many throwers, as we've said, have adaptive anterior laxity, which is a normal physiological finding, allowing their extreme range of motion. Differentiating this from pathological laxity or subtle instability can be very difficult, based solely on passive range of motion or standard laxity tests like load and shift.
So what's the key differentiator?
Most often, the most important clue is the patient's subjective sensation during the examination. Do they feel apprehension? Do they report a feeling of instability or impending subluxation when you put them into certain positions, particularly abduction and external rotation? That subjective report of apprehension or instability is often the critical differentiator, suggesting pathological laxity, even if the objective translation isn't grossly obvious.
Trust the patient's feeling.
Absolutely. And lastly, but certainly not least, we must pay close attention to the scapular assessment dynamically, as it's so intimately linked. We observe dynamic scapular motion from behind as the patient raises and lowers their arm, noting any obvious dyskinesis, asymmetry, or winging.
Any specific tests for scapular function?
Yes, tests like the Kibler scapular retraction test can be useful. Here, the examiner manually assists scapular retraction and upward rotation as the patient elevates their arm. If this maneuver relieves their symptoms, often anterior or subchromial pain, or improves their range, it suggests scapular dyskinesis is contributing. Another is the scapular pinch test, where the patient actively squeezes their scapula together and tries to hold it. An inability to hold for more than, say, 15 seconds suggests weakness or poor endurance of the scapular retractors, like the rhomboids and middle trapezius, which is common in these athletes due to fatigue or muscular imbalance.
Right, assessing the foundation's stability and endurance.
Precisely. It completes the picture.
Beyond the clinical exam, which is clearly paramount, what imaging do we typically need to confirm our suspicions, understand the extent of the damage, and crucially rule out other potential pathologies?
Radiographic evaluation is an essential adjunct, definitely. Though, as we'll discuss, it must always be interpreted within the full clinical context, never in isolation. We usually start with standard radiographs, plain X-rays.
What views are most helpful?
Typically, AP views with the arm in internal and external rotation, a scapular Y view, an axillary view, and sometimes a West Point view to get a good look at the anteroinferior glenoid rim. Now, while these X-rays may appear entirely normal, especially in the early stages,
Right.
they can reveal characteristic findings in more chronic cases of internal impingement. The classic one is the Bennett lesion, that bony spur or exostosis off the posterior glenoid rim, thought to be an extra-articular ossification resulting from chronic posterior capsular strain.
Okay, the Bennett lesion. Anything else?
You might also see some sclerosis or hardening of the bone at the greater tuberosity where the cuff attaches, or maybe posterior humeral head osteochondral cysts or lesions from the repetitive impact. Sometimes even subtle rounding or erosion of the posterior glenoid rim can be seen, indicating long-standing stress remodeling.
So, X-rays can give clues, especially in chronic cases. But beyond plain films, what's the gold standard for looking at the soft tissues, the cuff, the labrum, the capsule?
The mainstay of radiographic evaluation for these soft tissues is undoubtedly MRI magnetic resonance imaging. It offers high sensitivity for detecting capsular issues, labral pathology, and rotator cuff tears in the throwing shoulder.
Is MR arthrogram necessary injecting dye?
That's a good question. Traditionally, MR arthrogram, MRA, was often preferred for looking at labral tears. However, at our institution, and many others now, we routinely perform high-resolution non-contrast MRI. Robust studies have shown that with the right scanner strength, for example 3 Tesla, and appropriate pulse sequences, non-contrast MRI can have equivalent or even superior sensitivity and specificity rates compared to MRA for detecting these pathologies, and it avoids the need for an invasive intra-articular injection.
That's good to know. So what common findings might an MRI reveal that specifically point towards internal impingement pathology?
Common MRI findings in patients with symptomatic internal impingement often include posterior labral tears, sometimes extending anteriorly to become a sensilapp tear, often with that characteristic peel-back appearance. You'll frequently see partial thickness articular-sided rotator cuff tears.
On the underside of the cuff.
Exactly, on the joint side. Most notably, right at the junction between the supraspinatus and infraspinatus insertion onto the humeral head. That's a very typical location. You might also see cystic changes or edema within the posterior aspect of the humeral head, right where it impacts the glenoid.
Signs of impact?
Signs of repetitive impact, yes. Additionally, patients can display posterior capsular changes, like thickening or scarring of the posterior band of the inferior glenohumeral ligament, reflecting that tightness. And sometimes you can even see subtle subchondral bone bruising or remodeling of the posterosuperior glenoid itself from the repetitive microtrauma.
Can positioning during the MRI help?
Yes, adding an AB ear positioning sequence that's abduction and external rotation can be particularly insightful. It dynamically reproduces the position of impingement during the scan itself.
Ah, so you see the contact.
You can sometimes directly visualize the humerus and glenoid interacting, showing the contact between the cuff undersurface and the posterosuperior labrum, precisely as it happens during the throwing motion. This can really help confirm the mechanism.
That sounds incredibly comprehensive, but here's the absolutely non-negotiable takeaway for all of us listening. In internal impingement, MRI findings alone are rarely, if ever, enough to dictate treatment, are they? There's a crucial caveat you mentioned earlier that we need to hammer home.
That is a critical caveat, and one we absolutely cannot overstate. Numerous studies have shown that a high percentage of completely asymptomatic overhead athletes, especially elite pitchers, have significant abnormalities on their MRI scans.
Even without any pain.
Even without any pain whatsoever. We're talking about labral tears, partial cuff tears, capsular changes, things that look pathological on the image but are causing the athlete no functional problems at all. Halbrecht and colleagues, for example, noted that physiological contact between the cuff and the posterosuperior glenolabral complex was seen in both throwing and non-throwing shoulders of asymptomatic college baseball players when placed in that AB ear position.
So these changes can just be adaptations.
They can be physiological adaptations to the high demands placed on their shoulder, not necessarily pathological pain generators. Miniaci and others found MRI abnormalities in something like 80% of asymptomatic professional pitchers they scanned. So if you operate solely based on the imaging findings,
You might be fixing something that isn't broken.
you are potentially fixing a physiological adaptation, not the source of their clinical problem. Your hands-on examination, the patient's specific history and symptoms, and that crucial clinical correlation, these are always the ultimate arbiters. Surgical decisions should never be based on imaging alone. It serves as a valuable piece of the puzzle, confirming suspicions and mapping pathology, but it's not the entire picture by any means.
Clinical correlation is king.
Always.
Mm.
4/4. Charting the course. Treatment strategies.
Okay, so we've walked through the definition, the complex biomechanics, and the diagnostic process, integrating history, physical exam, and imaging appropriately. Now, let's say we've identified the problem. We have a diagnosis of internal impingement. What's the initial approach to treatment? Where do we start?
Right. The cornerstone, the absolute foundation of treatment for the vast majority of patients with internal impingement is unequivocally non-operative management. Conservative care.
Physiotherapy, primarily.
Physiotherapy. Rest. Activity modification. Yes. This should always be recommended as the first-line treatment. And it's crucial for both the clinician and the patient to understand that operative intervention should really only be considered if the patient has failed an adequate trial of physical therapy, typically for an extended period, maybe 3 to 6 months of diligent, focused, high-quality rehabilitation.
Why the strong emphasis on non-op first?
Because, frankly, the results following operative intervention for internal impingement, particularly in throwers, can often be unpredictable. They're not always as consistently successful as dedicated conservative care can be, especially if the underlying biomechanical issues aren't fully addressed. We generally observe more reliable success with committed non-operative approach first.
And this non-operative approach can be tailored, perhaps based on those Job stages of presentation we discussed earlier. It's not necessarily a one-size-fits-all program.
Exactly. It should be tailored. For stage eyes patients, for instance, those who primarily complain of shoulder stiffness and difficulty warming up, but have no significant pain with daily activities, a course of nonsteroidal anti-inflammatory drugs, NSAIDs, for symptomatic relief, combined with relative rest from aggravating activities, is usually the first step. Maybe some gentle stretching.
Okay. And for stage 2?
For stage 2 patients, those experiencing that isolated posterior shoulder pain, specifically during the late cocking phase, they typically require a period of rest from throwing or their aggravating sport, often 4 to 6 weeks initially. And these patients in particular can significantly benefit from a structured, targeted program of physical therapy. This is where the intensive rehabilitation truly begins to address the underlying mechanics.
Physical therapy then really seems to be the powerhouse here, the core of successful non-operative management. What are the specific components and critical elements of an effective physio program for internal impingement?
Physical therapy is indeed critical. It's both therapeutic, aiming to resolve the current symptoms, and protective against further injury, because it aims to correct the underlying biomechanical faults. The core focus of therapy must be the correction of those aberrant factors we identified. Abnormal shoulder range of motion, particularly GIRD, and scapular dyskinesis.
Right, hitting the key mechanical issue.
Exactly. We need to specifically address the elements that are contributing to the impingement, not just treating the symptoms superficially.
How do we specifically tackle GIRD, for instance? That loss of internal rotation is so prevalent and seems so important.
Yes, addressing GRD is a primary target. Special attention should be paid to correcting it through specific stretching exercises. The classic one is the sleeper stretch.
Can you describe that briefly?
The sleeper stretch is usually performed lying on the affected side with the shoulder abducted to around 90 degrees and the elbow bent. The patient then uses their other hand to gently push the forearm down towards the table, inducing internal rotation and stretching the posterior capsule. Studies have shown significant benefits from this. Daily sleeper stretches in tennis players, for example, led to significant increases in both internal rotation and total rotational range of motion, and importantly, were associated with a remarkable 38% decrease in reported shoulder problems.
That's quite an impact.
It is. The cross-arm stretch, pulling the arm across the body, has also shown effectiveness in stretching the posterior capsule and improving internal rotation.
Is stretching enough on its own?
Well, further studies, like work by Manska and colleagues, have shown that adding manual therapy techniques, specifically posterior glenohumeral joint mobilizations, performed by the therapist, in addition to the stretching techniques, can lead to even greater and potentially more sustained improvements in internal rotation ROM compared to stretching alone. So a combined approach often seems superior.
So not just passive stretching by the patient, but active mobilization by the therapist to enhance and sustain that mobility. Makes sense. And what about the scapula? That crucial foundation we keep coming back to.
Scapular stabilization exercises are absolutely crucial. They are essential for restoring proper scapulothoracic rhythm and ensuring the scapula provides that stable base. These exercises strengthen the muscles that control scapular movement and position the trapezius, upper, middle, lower, the serratus anterior, the rhomboids. Think exercises like rows, shrugs, push-up plus variations, YSTs, Ws.
The whole alphabet soup.
Pretty much. Ensuring those muscles are strong, coordinated, and have good endurance is key. And because the throwing motion is a full-body action, we must stress the importance of kinetic chain integration.
Right, connecting it all up.
Meaning core strengthening and lower body strengthening exercises are addressed simultaneously. You can't just focus on the shoulder in isolation. A chain is only as strong as its weakest link, and addressing the entire kinetic chain is fundamental for reducing load on the shoulder.
And mechanics, especially for younger athletes.
Absolutely. Finally, for younger athletes especially, but really for all throwers, proper throwing mechanics must be continuously assessed and reinforced, often through video analysis and skilled coaching, to correct any flaws that might be contributing to the stress and prevent recurrence. This really requires a collaborative effort between the clinician, the therapist, and the coach.
A team approach. What about injections? Corticosteroids are often used for shoulder pain. Are they a common part of the non-operative strategy for internal impingement?
That's often asked. Corticosteroid injections, usually directed under guidance toward the posterior-inferior glenoid rim or the specific area of cuff pathology, have been described in the literature for internal impingement. However, they seem to have been used mostly for diagnostic purposes, to see if numbing that specific area relieves the pain temporarily.
Ah, as a diagnostic tool.
Yes, more than as a primary therapeutic intervention. There is currently no compelling evidence or strong data to support their routine therapeutic use for internal impingement. Furthermore, they should always be used judiciously, particularly in young athletes with potential cuff pathology, due to the theoretical, albeit debated, risk of tendon weakening or damage with repeated injections.
So the focus remains firmly on addressing the underlying biomechanics through diligent rehab.
Exactly. That's where the long-term solution usually lies.
Okay. So let's say we've pursued a rigorous conservative course for several months. The patient has been diligent, but they're still symptomatic, still limited. If those non-operative measures don't provide sufficient relief, or perhaps if the initial pathology identified on imaging was particularly extensive, what surgical options are then on the table for internal impingement?
Right. When non-operative management fails despite best efforts, then operative intervention becomes a consideration. Now, because of the spectrum of pathology we often see associated with internal impingement, there are actually multiple operative treatment options, and the approach often needs to address several concomitant lesions found at the time of surgery.
It's rarely just one thing to fix surgically either.
Very often not. As we mentioned, it's a common finding reported in over 80% of professional overhead athletes undergoing surgery for this that they have concomitant articular-sided rotator cuff tears, and these are frequently associated with an adjacent kissing lesion on the posterior-superior labrum.
Cuff and labrum together.
Cuff and labrum damage together is very common. Therefore, the surgical approach must be highly tailored to the specific combination of pathologies found on the preoperative imaging and, most importantly, confirmed visually during arthroscopy.
Let's deep dive into some of these specific surgical procedures and, crucially, their reported outcomes. What's the current thinking around simply debriding versus actually repairing those partial cuff tears we see so often?
Okay. Historically, simple arthroscopic debridement, basically cleaning up the fray edges of the partial rotator cuff tear and/or the labral tear, was a common initial approach, and the results reported have been somewhat mixed.
How so?
Well, Andrews and colleagues back in the day reported quite optimistically something like 85% of their patients returning to premorbid function after arthroscopic debridement of partial supraspinatus tears. They attributed this success partly to the debridement stimulating some kind of tendon healing response.
Okay, promising early results.
Yes, but then other studies painted a slightly less rosy picture. Sunnery Katet and colleagues looked specifically at tennis players who underwent debridement of partial tears. They saw a decent return to play rate, around 79%, but significantly 91%. The vast majority still reported some level of persistent pain, even if they were playing.
So return to play doesn't always equate to being pain-free or performing at the same level.
Precisely. That highlights the challenge. Debridement alone might not be a silver bullet, especially for these high-level, high-demand athletes. It might not fully address the underlying pathology or restore normal function and comfort.
So how has the specific management of these partial rotator cuff tears evolved beyond just debridement? When do you repair?
The management of partial rotator cuff tears, particularly articular-sided ones in throwers, has definitely evolved considerably. Historically, a common threshold was that tears involving more than 50% of the tendon thickness were often repaired,
Right, the 50% rule.
the so-called 50% rule. However, more recent data and thinking, especially for high-level throwing athletes, suggests a more nuanced approach. Many now advocate that partial tears, even up to 75% thickness, should primarily be debrided unless they specifically involve a critical structure called the anterior cable of the rotator cuff.
The anterior.
Yes, this is a thickened band within the supraspinatus and infraspinatus tendons that acts like a suspension bridge cable bearing significant load. Tears involving this structure are thought to be less forgiving of simple debridement due to the tremendous forces generated by throwers, which can severely threaten the integrity of any repair attempt, but also lead to dysfunction if left torn. It's a complex decision.
Okay, so if repair is deemed necessary, maybe the tear is larger, involve the cable, or is in a younger athlete, what kind of repair technique is favored?
If partial tear completion and subsequent repair are indicated, then the technique matters. A lateralized double-row repair technique, as described by Dines and colleagues amongst others, should be strongly considered.
Why double row?
This technique aims to restore a more anatomic footprint of the tendon back onto the bone, potentially providing a more robust and biologically favorable repair construct compared to simpler single-row repairs. This approach has shown favorable outcomes in several series of professional overhead throwing athletes needing cuff repair.
So more anatomical, potentially stronger. And what about those SLAP tears? They're often found alongside the cuff tears. We know repairing SLAP lesions in athletes, especially throwers, can be notoriously tricky in terms of return to full function.
Yes, SLAP tear repair is indeed often an additional pathology we encounter, particularly type 2 lesions involving the biceps anchor detachment. However, you're right, the outcomes specifically in throwing athletes can be challenging and somewhat unpredictable.
What does the data show?
Neary and colleagues evaluated a group of high-level athletes who underwent type 2 SLAP repairs. They found only 57% were able to return to their pre-injury level of competition. Another 25% returned, but were still limited by pain or couldn't perform at the same level. So a significant number didn't get back fully.
Less than 60% returning fully. That's sobering.
It is. And crucially, they found a statistically significant correlation between the presence of concomitant partial thickness rotator cuff tears and the inability to return to the pre-injury level of play after the SLAP repair.
Ah, so the cuff tear was the bigger predictor of outcome.
It suggests that simply addressing the SLAP tear might not be sufficient if other underlying issues, particularly with the rotator cuff, are not adequately resolved or are perhaps too extensive to allow full recovery in these high-demand athletes. It really underscores that multifactorial nature we keep coming back to.
Right.
You have to address all the contributing pathologies.
Are there other adjunctive procedures that might be considered during surgery, perhaps to address persistent capsular tightness contributing to GIRD, or maybe that subtle anterior instability?
Yes, there are other techniques sometimes employed. Posterior capsular release can be performed arthroscopically as an adjunctive procedure specifically to address significant posterior capsular contracture and improve internal rotation, aiming to alleviate the GRD.
But that carries risks.
It does. It carries a recognized, though low, risk of injury to the axillary nerve due to its close anatomical proximity as it wraps around the back of the shoulder. So it's performed with extreme caution and only when significant tightness is clearly identified.
Okay. What about the front of the shoulder?
Well, addressing the anterior side, anterior capsular stabilization, typically a thermal capsulography or perplication, has been proposed by Andrews and others as a concomitant procedure if significant, albeit subtle, anterior laxity is deemed to be contributing. They reported high success rates, around 92% in their initial cohort.
But is that widely adopted?
Other studies have reported less optimistic results for anterior stabilization in the context of internal impingement, and it remains somewhat controversial whether tightening the front might actually worsen posterior impingement in some cases. It's not routinely done by everyone.
And any bone procedures?
Finally, in very select cases, some authors have proposed osseous procedures, like corrective humeral osteotomies designed to increase humeral retroversion, particularly in patients with persistent pain after prior debridement or repair, aiming to address the underlying bony adaptations directly. Riand and colleagues reported some success with this in getting patients back to sport. But these are definitely more complex procedures, typically reserved for highly select revision cases where other soft tissue interventions have failed.
So a real spectrum of surgical options highly dependent on the specific pathology found.
Exactly. Tailored to the individual. V, the road ahead. Prognosis, complications, and prevention.
Okay, so once a patient has gone through treatment, whether it was primarily conservative physiotherapy or they proceeded to operative intervention, what can they generally expect on their road to recovery? And perhaps more importantly for many of these athletes, how long does it typically take to get back to full function, especially at an elite level?
Right, the recovery journey and prognosis. It's important to state up front that the prognosis for individuals with internal impingement varies considerably. It really depends on several factors. The severity of the condition at diagnosis, how early it was identified, the specific pathologies present, and of course, the treatment approach utilized.
So lots of variables.
Lots of variables. What we can say with certainty, however, is that early identification and intervention are absolutely critical in preventing the onset or progression of degenerative changes within the shoulder joint. The sooner we intervene with an accurate diagnosis and a tailored rehabilitation program, generally the better the long-term outlook and the higher the chances of the athlete returning successfully to their pre-injury activity levels.
And in terms of a general recovery timeline, what sort of expectations should we be setting with our patients? Is it weeks or months?
Generally, for non-operative cases that respond well, recovery often takes between 3 to 6 months to get back to full sporting activity. However, for more severe cases, particularly those involving significant cuff or labral tears requiring surgery, or those with more chronic changes, it may require substantially longer, potentially up to a year or even more, for a full recovery, especially for high-level throwing athletes aiming to return to peak performance.
A year or more is a long time out.
It is. And following surgery, the typical initial recovery involves the arm being placed in a sling for a period, maybe 1 to 2 weeks, sometimes longer depending on the repair, primarily to limit mobility and allow for early tissue healing. This is then followed immediately by a very carefully graduated rehabilitation program.
Starting gently.
Starting gently, yes, often with passive motion first, then active assisted, then active, followed by progressive stretching and strengthening exercises. Most individuals undergoing surgery can expect to return to their pre-surgery activities within perhaps 4 to 6 months. But again, some, especially elite throwers, may face significantly extended recovery times depending on the complexity of their surgery and the demands of their sport. It really is a marathon, not a sprint, particularly after surgery.
What about the overall outcomes we see for these different treatment strategies? Are certain approaches proving more effective than others in the long run? And what does the latest evidence suggest regarding specific rehabilitation protocols, perhaps accelerated versus delayed?
Looking at outcomes, studies comparing conservative approaches suggest that both manual therapy combined with exercise and exercise therapy alone can significantly improve pain and functional capacity in patients with shoulder impingement syndromes generally.
Does adding manual therapy help?
Yes. Interestingly, the addition of manual therapy techniques by a skilled physiotherapist has been shown in some studies to yield slightly better outcomes, particularly in terms of faster pain reduction and improvements in range of motion compared to exercise alone.
Okay. And after surgery, say for a cuff repair?
Regarding long-term outcomes specifically for rotator cuff repair, which is often part of the surgery for internal impingement, there's been interest in rehabilitation protocols. Some meta-analyses have indicated that accelerated rehabilitation protocols starting motion earlier might demonstrate slightly better forward flexion at the 12-month follow-up compared to more traditional delayed protocols.
So faster might be better, potentially for some aspects of recovery. However, the overall evidence suggests that both early and delayed protocols can yield comparable long-term effects on overall shoulder function and repair integrity. There's still debate, and it often comes down to surgeon preference and the perceived quality of the repair tissue. Caution is warranted due to the variability in study methodologies and patient populations. But what's undeniable is that consistent, high-quality, and patient-specific rehabilitation, guided by a knowledgeable therapist, is the absolute key to successful outcomes, regardless of the exact protocol timing.
The quality of the rehab is paramount.
Absolutely.
Now, while recovery is often successful, we must also address the potential pitfalls and complications. What are the common risks associated with internal impingement itself or its treatment, particularly after surgical intervention, that we need to be aware of and counsel our patients about? Yes, complications can occur. One of the most commonly observed postoperative challenges actually relates to shoulder range of motion. Limited shoulder mobility, stiffness, or even developing conditions like capsulitis or a true frozen shoulder can be a significant issue after surgery.
Stiffness is common post-op.
It is, and it can be incredibly frustrating for athletes trying to regain their full mobility and function. This really underscores the immense importance of careful and precise rehabilitation planning, especially in the early postoperative period, finding that right balance between protecting the repair and progressively restoring motion.
What are other specific risks?
Other potential risks include the possibility of progression to a full-thickness rotator cuff tear if only a debridement of a significant partial tear was performed, rather than a full repair, particularly if the athlete returns to high-demand activities too soon or with inadequate strength.
The tear getting bigger?
Exactly. We also sometimes see a delayed rate of return to play, which can often be worse following formal rotator cuff repairs in high-level throwing athletes compared to simpler debridement procedures, even if the long-term outcome might be better with repair. There's that trade-off. And as we discussed earlier, there is that distinct, though thankfully rare, risk of axillary nerve injury during posterior capsular release procedures, which is a serious potential complication that needs careful surgical technique to avoid.
Okay, so definitely things to be aware of. Ultimately, prevention is better than cure. How do we empower athletes, coaches, and clinicians to prevent this condition from even starting in the first place, or at least stop it from progressing? What are the crucial primary prevention strategies we should be advocating?
Prevention is truly paramount, especially in this high-risk population where the very act of their sport predisposes them to potential injury. Education has to be number one.
Educating who?
Educating the athletes themselves, particularly those in throwing and other overhead sports, but also coaches, parents, and even relevant laborers. They should be thoroughly instructed on proper warm-up techniques, specific strengthening exercises for the shoulder girdle and kinetic chain, and correct throwing or overhead work mechanics to mitigate their risk.
In recognizing symptoms early.
Absolutely. Understanding the early warning signs of internal impingement, like that need for a longer warm-up, subtle velocity drop, or that deep posterior ache after activity, is also vital for encouraging timely intervention before it becomes a more chronic stage 3 problem requiring extensive treatment.
Can you provide a bit more detail on the recommended types of strengthening and flexibility exercises specifically for prevention? What should a comprehensive prehab or maintenance program look like?
A comprehensive program designed for prevention or prehab should really include regular isotonic dumbbell resistance training. This needs to specifically target the key rotator cuff muscles, supraspinatus, infraspinatus external rotators, subscapularis internal rotators, and, crucially, the scapular stabilizers.
So, cuff and scapula focus.
Cuff and scapula focus, yes. These aren't just general gym exercises. They should be tailored to the biomechanical demands of the overhead activity. Specific exercises like shoulder shrugs for upper traps, various types of rows for mid-traps rhomboids, push-up variations for serratus anterior, and various deltoid movements should be performed regularly, perhaps 2 to 3 times a week, to enhance muscular strength, balance, and endurance throughout the entire shoulder girdle.
And flexibility.
Yes, alongside strengthening, maintaining flexibility is key. Manual therapy techniques, if accessible, and regular self-stretching exercises, like the sleeper stretch and the cross-arm stretch for the posterior capsule, are highly recommended to maintain or improve internal rotation and overall shoulder joint mobility and stability. The key is regularly incorporating these activities into training routines, making them part of an athlete's normal preparation or recovery, not just something done when problems arise.
Making it routine. What about activity modification? Is it always about stopping activities, or can we modify them?
Activity modification is also a key component, particularly managing load. Individuals identified as being at risk should be educated about avoiding specific movements or training patterns that might exacerbate shoulder strain. This could mean adjusting volume or intensity of throwing, modifying certain gym exercises, like avoiding deep dips or behind neck presses, or ensuring adequate rest periods.
Smart training.
Smart training, exactly. And maintaining awareness of body posture during daily activities is also surprisingly critical, as subtle postural deviations like excessive thoracic kyphosis or forward head posture can accumulate and increase stress on the shoulder complex over time. It really is about a holistic approach to shoulder health. 247.
And finally, the ongoing role of monitoring and early intervention, especially for our high-risk, high-level athletes.
Absolutely essential. Regularly monitoring shoulder function, range of motion, strength, and scapular control, particularly in high-risk individuals or those with a history of symptoms, is vital for early detection and intervention. Preseason screening programs can be very valuable here.
Catching problems before they escalate.
Exactly. Any rehabilitation or prevention program should focus on maintaining pain-free range of motion and gradually progressing strengthening exercises appropriately. This proactive approach allows for a much quicker response to any emerging subtle symptoms or functional deficits, potentially preventing the progression of internal impingement to a more severe and possibly career-threatening condition. It's really about being proactive, not just reactive, in safeguarding the athlete's long-term shoulder health and allowing them to continue pursuing their passion.
A proactive partnership between the athlete, coach, and medical team.
That's the ideal, yes.
So, wrapping this up, what does this all mean for us as clinicians dealing with these athletes? We've delved deep into internal impingement today, peeling back the layers of its complex pathology from those precise anatomical interactions and its historical definition, right through to its multifaceted pathophysiology involving the kinetic chain and adaptive changes. It seems absolutely clear that understanding this intricate interplay of biomechanics, those paradoxical adaptations, and the specific clinical signs is paramount for accurate diagnosis and truly effective management.
Indeed. I think the insights we've discussed today, from the nuances of the kinetic chain analysis and that fascinating thrower's paradox, to the absolutely critical roles of GRD and scapular dyskinesis, they all highlight that effective management demands a truly holistic, patient-centered approach. You can't just focus on one structure seen on an MRI. Ultimately, our goal isn't just to treat the immediate injury, is it? It's really to empower these athletes to sustain their careers, to continue participating in their passion for sport for as long and as healthily as possible. And this, I think, raises an important ongoing question for all of us in the medical community. How can we continuously refine our preventative strategies, our screening tools, and our rehabilitation programs to truly safeguard the long-term health of the overhead athlete's shoulder? How do we shift the paradigm even further from reaction to proactive preservation?
A powerful thought and a vital challenge for us all to consider moving forward. If you found this deep dive valuable today, please do consider rating and sharing it with your colleagues. Your insights and support really do help us continue to bring you these in-depth discussions on complex topics. Thank you for joining us on the deep dive.